Okay, Konstanty, please welcome.
So thank you very much for having me here. I tried to translate this lecture into Ukrainian, but it's Google translation, so excuse me if it's not right. And it might take me some time reading my own slides, so sorry about it. So this is about lung protective ventilation, and is there anything new about it, and whether we understand it correctly. So these are the lungs that we sometimes have to ventilate. The problem with lungs like this is that the only part that we can ventilate is this dark part, right? This part is aerated, it's full of air, and all the rest is collapsed, and we cannot ventilate it. So the art of mechanical ventilation, lung protective ventilation, is how to keep the patient alive, ventilating such a small volume of the lung and not to destroy it, right? So this is lung protective ventilation, and this small size of aerated lung is called the baby lung. Why baby? Because it's very small. It's like in the baby, but it's in the adult. So the concepts of mechanical ventilation in ARDS in principle changed over time. So first it was only about providing appropriate gas exchange. Now we are aiming at more individualization, and I'll show you why this individualization is necessary. So at first it was realized that it's tidal volume which is harmful. If we give too much tidal volume and there is too much plateau pressure, the patients basically die. So too much pressure means high risk of mortality in these patients. We have current guidelines that were published nearly 2 years ago now, but there is frankly nothing new, and unfortunately all the things that are most important are not there because they are not based on randomized controlled trials. So these guidelines basically confirm that we should use reduced tidal volumes like 4 to 8 milliliters per kilo, and this is it, and it's based on the very old paper from 2000 showing that 6 mils per kilo is better than 12 mils per kilo. However, shortly after that study, another study was published, and you can see both these patients are ventilated with 6 mils per kilo. This patient on the left has larger baby lung, the aerated lung is larger, there is less collapse, and the one on the right has more collapse, so the baby lung is smaller. And you probably can see these red dots on the right, and these red dots, it's hyperinflation. It's too much air pushed into too small baby lung, and they are both ventilated with 6 mils per kilo. Okay, so this shows that even 6 mils per kilo might be too much for some patients, and it's not that 6 mils per kilo is a cent value of tidal volume, it's just better than 12. But what we should do, we should adjust the tidal volume to the size of the baby lung, okay, to fit the size of the baby lung. And how we can do that? There are several modalities. There is certainly a CT scan, but to do CT scan you have to go with a patient to the CT, and these are usually severely ill patients, so it's not so easy to go there. There is new modality which is getting more and more popular, and which I personally like very much. This is electrical impedance tomography that you can see here. There will be several words about it. And there is another modality which used to be available in GE ventilators. Currently there are not more on the market, but you can buy them in other ventilators. There is this technology called nitrogen washing washout. You change the concentration of oxygen in the mixture on the ventilator, and then you measure the amount of nitrogen in the air that is breathed out by the patient, and by that you can measure the amount of end expiratory lung volume. This is called nitrogen washing washout method. and it's quite useful. So with that, you can assess the size of the baby lung. You see, FRC, in fact, it's not FRC, it's called ELV, end expiratory lung volume. But this is the size of the baby lung, okay? And you can adjust tidal volume to the size of the baby lung. If you measure it, you can adjust the tidal volume to that. Because that was proven by Luciano Gattinoni's team, that ideal mechanical ventilation should aim at tidal volume, which is 25% of FRC. So if you measure FRC, you can adjust tidal volume, okay? And you can set different values of PEEP and see at different values of PEEP different size of the baby lung. So first you optimize the size of the baby lung with PEEP to get as much baby lung as possible, and then you can adjust tidal volume to the size of the baby lung. And in fact, together with Giacomo Bellani, we performed this small study, if it's possible, with measuring the size of the baby lung with nitrogen washing and washout technique, to adjust tidal volume, and it is possible, and you can normalize strain. So you can set tidal volume at 25% of the baby lung. It is possible, it can be done. There are some remarks, so it's not always so easy, but the question is, if we really need to measure the size of the baby lung, because maybe we don't need to measure the size of the baby lung, because there is this very famous paper that shows us that in fact the most important risk factor is driving pressure. And driving pressure is a way of adjusting tidal volume to the size of the baby lung. If you deliver to the patient tidal volume that is too much, you have to use high driving pressure. So if you use high driving pressure, it simply means that you are delivering too much tidal volume to the small size of the baby lung. It's very simple. So you don't have to measure the size of the baby lung. It's all about driving pressure, and driving pressure seems to be the most important risk factor in mechanical ventilation. However, it's not included in current guidelines. Why not? Because it was only from observational studies, not from randomized studies. So the amount of data that we have is not enough to include it in the guidelines, even though it's probably the most important factor. It's the driving pressure. And how to measure the driving pressure, which we probably all know, this is the difference between the plateau pressure and PEEP. So you push the inspiratory hold, you measure the plateau pressure, and then the difference between plateau pressure and PEEP is the driving pressure. And it was shown in several other observational studies that if you increase driving pressure, you increase mortality. This is one of the studies from a friend of mine, Giacomo Bellani, the LungSafe study, and it clearly shows that when you use the driving pressure of above 14 centimeters of water, the mortality was significantly larger. What about PEEP? There is no recommendation in the guidelines regarding PEEP. Why not? Because there is no single PEEP that is better for the patient. What is best for the patient is the PEEP that is individualized, that is individually adjusted to the patient's needs. So there are different ways of adjusting PEEP. This is one of probably the most stupid ways. These are so-called ARDS network guideline tables. But yeah, there is something, okay? Probably not the wisest way. Another way is this method that I showed you, nitrogen washing, washout, to optimize the size of the baby lung, and at the same time you can see, you can have the static compliance. So the combination of best compliance and best size of the baby lung, that should be probably somewhere here, is the optimal PEEP. Guess what is the problem during mechanical ventilation of patients with collapsed lung? We have two mechanisms going on in the lung. On the one hand, there is some part of the lung that is collapsed, but there is still some perfusion. There is blood flowing through the collapsed lung. And this is called shunt. So this is blood that is not oxygenated in the lung, and it's so-called venous admixture. And you can increase oxygen, and patient is still hypoxemic because the patient has shunt. And the other problem is physiologic dead space. So there are parts of the lung that are ventilated but are not perfused. And so some of the ventilation is wasted. It's not used for gas exchange because there is no blood flow. Okay? So on the one hand, we have shunt. On the other hand, we have physiologic dead space. And this is what happens when you administer PEEP. This is a very famous picture from a very famous man, Göran Hedenstierna from Uppsala in Sweden. He was performing wonderful research on respiratory physiology. And this is dog's lung. Dog's lung, and you can see these are alveoli. This is alveolus, okay? And these are alveolar capillaries. And these black dots are erythrocytes in the alveolar capillaries. And when this one on the left is with no PEEP, and this one on the right is with PEEP, okay? So when you administer PEEP, what you can see is the collapse of the capillaries, okay? And the flow is redirected to so-called corner capillaries, but all the rest is collapsed. So this is what is called a hyperinflation. If the PEEP is too much, it's beautifully aerated, it's full of air, but there is no flow, there is no perfusion. So what is this? This is dead space. It is ventilated, very well aerated, but there is no perfusion, there is no gas exchange. So that's not good, and we have to avoid it. And this is the problem, that when we ventilate the patient, such as this, and we administer too high PEEP, we cause hyperinflation in the ventilated or aerated parts of the lung. So we damage the good parts of the lung, and we don't use them if we use too much PEEP. Because what happens when you give too much PEEP is that you redirect flow into the parts of the lung that are collapsed. Because in the collapsed lung, there is no PEEP, so there are no collapsed capillaries. Okay? So this is the problem with too much PEEP. Too little PEEP is collapsed lung, too much PEEP is hyperinflated lung, and it's not good either. Okay, so what happens if there is too much PEEP? You can see the capillaries collapse, there is flow redirection into corner capillaries, or flow redirection to the other parts of the lung. Okay? So this is absolutely not good for the patient. Too little PEEP is bad, too much PEEP is not good either. So you can see why there is no recommendation regarding certain PEEP, higher or lower in the guidelines. Because what the patients need is titrated PEEP, individualized PEEP. Okay? And it's very important because there is this famous paper from Nacton that showed that when you, it's cut, I'm afraid, if there is an increase of dead space of 5%, that increases the mortality by 45%. Okay, you can see this is the odds ratio here. It's 45% increase in mortality. So too much dead space is increased mortality. And this is a very nice slide from others, a study showing that increasing PEEP is only good when it increases oxygenation. So when you increase the PEEP and it improves oxygenation, that means that you improve patient survival. But if you increase PEEP and it does not improve this saturation, it means that it's probably not improving the survival either. I'll skip these slides for the sake of time. This is something quite interesting from ART trial. You probably know that there was a study called ART trial. They were using recruitment maneuvers and increasing PEEP after this recruitment maneuvers. And what they got was increased mortality. Why was that so? Because they were probably using too much PEEP. But as you can see here, there seems to be a difference between patients with pulmonary or extrapulmonary ARDS. Pulmonary ARDS is just severe pneumonia that led to ARDS, while extrapulmonary ARDS is most likely sepsis. And you can see there is a significantly different trend, and you can even see that in the old papers from Luciano Gattinoni, that when you perform a recruitment maneuver in the patients with focal ARDS, this is pneumonia, you get a lot of hyperinflation and very little recruitment. But in extrapulmonary ARDS, like in sepsis or severe hemorrhage, you get significant recruitment and not so much hyperinflation. So the patients with ARDS differ, and they differ a lot, and that was a very famous study called LIFE study from Jean-Michel Constantin from Paris, who wanted to see whether you can adjust the PEEP based on how the lung looks. And they were looking at chest X-ray and saying this is a focal ARDS, so pneumonia, and this is non-focal ARDS, so like sepsis. And they were trying to adjust PEEP based on that. In non-focal ARDS, like sepsis, they wanted to use high PEEP, and all the rest, in focal ARDS, they wanted to use low PEEP. But the problem was that they made a mistake, and they misclassified the patients. And in some patients who were misclassified, and they were focal patients, so pneumonia leading to ARDS, when they used too much PEEP, they get a survival like this. You can see it here, okay? The lower graph here, very low survival, 20%. But when they used appropriate PEEP, the survival was more than 80%. So we can harm the patient when we misadjust the PEEP. And this is a very nice study. It was a negative study, very poorly designed study. But it shows us that we can harm the patient when we misadjust mechanical ventilation, and how harmful mechanical ventilation is. There is this technique called electrical impedance tomography. I won't be describing it. You probably know it. We like it a lot. It helps us titrate mechanical ventilation. But we need more personalization, and this is one of my last slides. You can see that another marker of injurious mechanical ventilation is mechanical power, okay? But it seemed that with same amount of mechanical power, mortality was significantly higher in women than in men. Yes, so women are more sensitive, more fragile, so maybe they die more from mechanical ventilation. But when they adjusted the mortality depending on the mechanical power and the compliance of the lung, it turned out that increased mortality in women was not because they were women, but because that was the same amount of mechanical power applied to a smaller lung. So it's not about the amount of mechanical power that we give with a ventilator, but the size of the baby lung that this mechanical power gets into. Because the smaller is the size of the baby lung, the smaller is the size that gets all this mechanical ventilation, mechanical power. Because if you think about it, what is the ventilator? What is a ventilator? A ventilator is a machine that transforms electrical power from the socket when you plug it. Then it transforms electricity into lung damage. There is some energy used for display and for stupid sounds, but all the rest gets into the lung and it damages the lung. Okay? So mechanical ventilation nearly always damages the lung. There are calculations comparing how respiratory rate translates into driving pressure, but it's very important, it's cut again, that every day of mechanical ventilation that was not appropriate increased the mortality by 6%. And this is, in fact, last slide. So these are the pig's lungs ventilated. This is without mechanical ventilation, sham. Non-protective was 12 milliliters per kilo. 6 milliliters per kilo was conventional ventilation, and near apneic was 2 milliliters per kilo. Okay? So what you can see that even with 2 milliliters per kilo, mechanical ventilation still induces some inflammation in the lung, some damage. So that means that mechanical ventilation probably always damages the lungs, but we can decrease this damage by individualizing mechanical ventilation, by decreasing the respiratory rate, because respiratory rate also increases the mortality, as you can see. And the time of mechanical ventilation also counts, so the longer we ventilate the patient, the worse it is for the lungs. Thank you very much.